Hi, Rob Gooch from NHSX, here to walk you through the published implementation guidance for digital medicines that goes with the published Information Standards Notice and the UK Core Standard for medicines interoperability within the NHS. The link for this page that you're seeing on screen was provided in the slides in the ePrescribing Masterclass. This landing page, two important links on this. First of all, a link to the published Information Standards Notice, and also a link to the published UK Core Standard. This UK Core Standard, the audience for that is primarily going to be your system suppliers. The audience for the ISN is going to be you and your team within the trust, as well as the system suppliers. This document, guidance document, works for two audiences. There are pages that are primarily for your system suppliers, giving them specific guidance on implementing the FHIR standard for medicines use cases. But there's also pages in there for you and others within the implementing organizations to guide you through the process of implementation. It's not a complete guide. This guide will be updated periodically as we learn best practice coming out of regional implementations, as we learn what works, what was problematic, what's proved successful. So this will be the medium which we can share the best practice and the learning from around the country to help everyone deliver interoperable med solutions. So this document, I'll walk you through some of the key pages so you know where to get information or where to look when the information gets updated. First of all, within the FHIR Assets page, this is for the technical information. Most of this is now just links through to the UK Core Standard, with the exception really of this link up here, which is where we have published the implementation guidance for dose syntax. So this page for the dose syntax, it first of all gives you a representation of the dosage model in FHIR. So yes, that's relatively technical, but they're the different data elements that can be used to describe a dosage in a machine readable way. But for each of those elements, we have implementation guidance specific to those. So if I just jump down to say the timing, frequency and period guidance, this gives you a description of what this is, what it's for. It's for describing frequencies. You can describe frequencies as number of seconds, minutes, hours, things like that. And then a combination of the frequency, the period, and the period unit can define different frequencies. So there's a number of examples: 8 every 8 hours, 4 times a day, 2 to 4 times a day, etc., etc. So just a few examples, not everything, because there's hundreds of combinations of frequencies. But this gives you a feel if you can just pick out the business data. So every 3 to 4 weeks, the period and the period max. So this gives you a feel for the different parts of the dosage structure. So look through those, how sites are represented, how route is represented, method, dosing rate, things like that. In the design section, we have an overview that walks you through some of the key questions that need to be asked when you are building or designing any meds interoperability solution. First of all is knowing and understanding the DM&D standard. So DM&D standard, some of the key aspects summarized on one page. So first of all, the DM&D model, the different concepts, the different concept classes for DM&D, from the most generic concepts, the virtual therapeutic moiety, down to the most specific concept, the actual medicinal product pack. And we have an example of ibuprofen to show how that is represented at each of those levels. Some description about the product-based versus dose-based approach. This is fundamental for Meds Interop. Product-based instructions are always used in primary care and sometimes used in secondary care. Dose-based instructions are typically used in secondary care. And for Meds Interop, we need to be able to work with both and convert between both for effective transfers of care, where you are getting product-based instructions, say from a GP record. You need to be able to convert them to dose-based instructions, and vice versa. On discharge, you may have dose-based instructions in your EPMR. They need to be converted to product-based instructions so that a GP can understand them and set them up in the GP system for ongoing prescriptions. A diagram gives an example. We used ibuprofen again. As a dose-based instruction, it could be as simple as ibuprofen, 100 milligrams 4 times daily. Because on a ward, the ward staff may determine the best form for that, whether it's a tablet, whether it's given in liquid form, and via what route. Whereas in primary care, on a product-based prescription, the form, often the route, are all then specified as part of that product. Here I've chosen just a 100 milligram chewable capsule. There are many other products available, and we have then chew one capsule 4 times a day. So the same amount of ibuprofen is going in, 100 milligrams 4 times a day, 100 milligrams 4 times a day, but we have completely different types of instruction. And then also we have information about the different levels again of the DMD concepts, and using a paracetamol 500 milligram example, how that would be represented as a dose-based instruction using a BTM there, and then how you could additionally qualify that by a form. In this case, we're saying this we need it as a suppository. How you could specify it and be specific with brands. So here we're looking specifically for Panadol as a product, paracetamol 500 milligram tablets, and see how then the dose changes from expressing it as a strength to expressing it as a number of tablets, because we are now describing it as a product. And then with a quantity unit measure, so this would be typically how you would see that coming out of a GP system. A product, the dose, 1 tablet twice a day for 7 days, and then a quantity. I want the pharmacist to dispense 14 tablets. And then as an actual medicinal product with specifically which manufacturer we want. And then finally, the most specific, we've got the drug, the manufacturer, the dose, and the requested quantity. Then, what are your target use cases for your project? So we have a page describing various target use cases. I won't scroll all the way down. We'll just go to this diagram. We have a number of use cases for medicines. Meds on admission, understanding what the patient's current medications are, getting them from various sources, which may be product-based or dose-based, and being able to get a view of those to understand what needs to be continued, started, stopped during that patient's inpatient stay. Supplying patient meds, the ward meds, the requests that go to the hospital pharmacy, the meds that come back, that interoperability between the EPMA system and the pharmacy stock control system. Hospital transfers, both between hospitals, if the patient's moving to another hospital to receive any kind of specific care, the information about their current meds needs to go across, but also transfers between wards within a trust. Again, if they're using different clinical systems, you need to get the data between those two systems. Meds on discharge, this is again key for the product-based versus dose-based stuff, making sure that the medicines information going back to the patient's GP is understood, so the right meds are stopped and the right meds are started, and there's continuation of the patient's care when they leave the trust, but also making sure the relevant information is available to the shared records, so everyone who cares for the patient can see changes in their medication resulting from their inpatient stay. The electronic prescription service, a whole system there. Use of FHIR is being brought into that system as well, and shared records. the regional shared records that are all now being worked up around the country, making sure that we have consistency in how medicine information is represented in those, and common ways in which the medication gets into shared records and be queried from shared records. Then we have two other pages around sort of high-level architectures and shared record architectures that are mainly for your system suppliers. So I won't show those, but there's links there and there. The build sections are mainly for your system suppliers, but there is some guidance there about how to do the translation between dose to product. We haven't got product to dose yet. That will be added, and how to convert from structured dosing into a human-readable text instruction, essential for then displaying on the screen. And then the last bit I want to show is under the examples. We've got a number of examples of each of those use cases, showing you the actual message that would go from system to system. That's obviously primarily for your system suppliers. But we have 2 pages showing lots of structured dosing examples. We have a number that are fully coded. This means this dosing instruction is completely machine readable. And I'll just walk through the first one coming on the list, which is aspirin dispersible tablets. So yes, it's in XML format, so I'll pick out the business data so you can see how to read this. I can also show it in JSON format. So it's up to you whether you prefer looking at it like that or like that. Let's go to JSON. So the business data here for this medication request. So this would be something that would be sent to a dispenser, to a pharmacy system saying, please, I need my patient to be on certain medication. So here we have the drug. This is a VMP, aspirin, 300 milligram dispersible tablets. There's the DMD code, tells you it's a DMD code. Okay. Then we have a dosing instruction. Ignore the text for now, I'll come back to that. But we hear now the dosing instruction is, I want 2 tablets. Tablet is explained is referenced in the singular. 2 tablets. And I want that 4 times a day. Frequency 4 times D is day. And then this when is coded C means with a meal. So 4 times a day with a meal. And then I want to make sure that there's some maximum dosing instruction there. So the max dose per period here is 3.6 grams every 24 hours. And I've got an additional instruction, which is SNOMED coded. There's your SNOMED code. Dissolve or mix with water before taking. This is a dispersible tablet. So all this information is fully machine readable. But you as a human don't want to see that on screen. But we can use, your systems can use an algorithm that we've published, and we're going to make this a service as well, so they can convert that into a consistent string. So on screen, you will see something like this. This is what we're proposing, a consistent dosing string, which is all machine readable, but that's then consistently displayed for you as a human. So we have a number of the examples, lots of them there, including an insulin, and we'll certainly be speaking to Claire following her presentation on maybe adding some more examples to insulin and making sure that they're consistent with the good practice that Claire was sharing earlier. We also have some examples where they're not fully machine readable. These are the edge cases. These are where there's some element of free text instruction that has to be included. So these are the edge cases, and in each case it tells you what the edge case is and why a free text instruction needs to be included alongside all the coded instructions. So some of those drugs will be familiar to you, so look through those, and we always welcome feedback. This is work in progress. The more clinically verified examples that we can publish, particularly the problem ones, the edge case ones, the ones that are difficult, the better, because it can help everyone understand that how the fire standard is going to give us the interoperability that we need to make to improve all those use cases that we described. So this is the landing page, and there's the link to the ISN, link to UK core, information about understanding the dosing instructions, some of those key design decisions, and we'll extend this guidance as we go along, and lots and lots of examples.